Yes? Okay. Well, can I welcome you all to this meeting of the Health and Wellbeing Board? My first task is to welcome new members of the committee. So hands up those of you who are new, because I'm new. So perhaps you could introduce yourselves.
Councillor Jennifer Gould.
Councillor Brenda Fraser, Cabinet Member for Children's Services.
And I'm Councillor Peter McCabe. I'm the Cabinet Member for Health and Adult Social Care. Are there any other people who've not attended before? Who are we talking about? Would you like to introduce yourself? We think you're on mute, Sarah.
I'm sorry, it's dropping in and out. Apologies. Hi, I'm Sarah Goad. I'm the newly appointed CEO at Age UK Merton, and this is my first board here.
Well, welcome to Sarah. I met her recently for the first time, and I think she'll be a very welcome addition to the proceedings, as are all the new members. Jennifer and Brenda, welcome, and sort of look forward to working with you, and congratulations on your new roles respectively. So apologies for absence. We do have some apologies.
Yes, Chair. Apologies were received from Dr. Aditi Shah and Jane McSherry.
And the next item is declarations of pecuniary interest. Do we have any declarations? No? Okay, you're doing very well. Item 3 is minutes of the previous meeting. Are they agreed? Great. Item 4 is living with COVID, and that's a verbal update from Dagmar.
Thank you, Chair. And dear members, you might be a bit tired hearing me talking about COVID, so I will keep it very brief. The reason I bring living safely and fairly with COVID to the board is to remind you that the board has a role in the governance and oversight of our COVID preparedness and living with COVID. So it is a brief reminder on our role. Living with COVID, instead of the acute response that we are all happy having left behind us, means that we are now treating COVID as any other respiratory infection. Think about flu. The specific differences to the COVID 2 years that we've just left behind us is there's no more testing, there's no contact tracing, but very, very importantly, there is vaccination. And it is up to our civic duty that if we have symptoms, that we try to stay away as much as possible. Now, how are we dealing with COVID now? You will have heard in the news probably that the Omicron variant that gave us a lot of angst around Christmas has produced more subvariants. They have fancy names, BA4 and 5. Infections are actually up, even in the hospital, there's a little bit more. But I think it is now in a stage that we can contain and cope with this. We're expecting waxing and waning of further infections, but not further searches of really serious disease, unless nasty variants are around the corner. So our role as a health and wellbeing board and local authority is to cope with what we see now, the waxing and waning, supporting people with ongoing vaccinations, looking after people with long COVID, ensuring that the most vulnerable have access to therapies. And if the situation deteriorates and we would see another really nasty variant, then it is very important we would not live just happily with COVID as if it's just a bit of flu. Then we would have to flip back into the acute response. This would be led by the UK Health Security Agency at national level, and we would be in a different scenario. So that gives you a little bit of a flavor. We had a very active and effective Health and Wellbeing Board community subgroup that kept the dialogue with the community throughout the pandemic, really managed good engagement. And the subgroup has stood down, but is there ready if, let's hope we never need it, but if needed, we can stand it up again. We're also looking at legacy because it was a tough 2 years, but we've learned a lot, particularly around IPC, infection prevention and control. We've embedded it a lot more, particularly in our care homes, home care, adult social care settings. And as I mentioned, engagement, really important. We're still very much working with our network of community champions with the voluntary sector. So there were some really good things that we want to build on. I leave it at that. Any questions from the members? Happy to answer.
Thank you, Dagmar. Are there any questions? No? Okay. Final answer? You don't want to ask a friend? Okay, well, in that case, we'll move on to the next item, which is the Merton Carer strategy. And that's Heather. Who's actually presenting this?
I am, Chair. So my name's Heather Begg. I'm a commissioner in adult social care and overseeing the carer strategy work. So the Health and Wellbeing Board have asked for us to provide a progress update on the Merton Carer strategy. And I am joined by two key partners with me today, who are, I can see on the screen, the CEO of Carer Support Merton, Tracy Waite, and Sally Burns, who is a carer representative, and we'll be hearing from them a little later on, if that's okay. So the Merton Carer strategy was launched at an online event last June, but we started a little bit before that. And there are 4 key elements to the carer strategy document. I've got a copy here. Identification, recognition and contribution, health and well-being of carers, realising and releasing potential, and a life alongside caring. When we actually developed the strategy, we engaged with over 200 carers and approximately 50 professionals from a range of organisations to write this strategy. We then refreshed the strategy after talking with carers as a result of COVID-19. And as we know, the impact of carers, informal carers, over the last 2 years has been absolutely immense. So the Health and Wellbeing Board approved the strategy in November 2020. And as I said, officially launched the strategy as part of Carers Week last June. And we've actually just had a really successful Carers Week a couple of weeks ago, actually, the 6th to the 12th of June, where we finished off the week with a carers celebration picnic in Morden Hall Park, which was absolutely lovely to really celebrate carers and to start seeing carers face to face in quite a safe environment as well. So we had 11 priorities. We couldn't, it's a 5-year strategy. We couldn't do everything all at once. So we chose 11 priorities for the first year. And we also have joined the Young Carers strategy, Merton's Young Carers strategy, with the multi-agency carers strategy into just one implementation plan. And that's been really positive. We have got 4 well-attended multi-agency subgroups that link to the 4 key outcomes within the strategy. which includes carer representatives, the council, health partners, and other partners such as our voluntary sector organisations to work together to make lives better for the carers in Merton. And each subgroup is working through the priorities together. And I just wanted to give a little bit of a flavour on the next slide, please, Clarissa, sorry. To just give you an update on what we've been up to in those groups. So the groups meet every 6 to 8 weeks, and we're working through an implementation plan. One of the key things for subgroup 1 is that identification. So we're working closely with GP practices to identify and support carers. This is not just identifying a carer and referring off to Carer Support Merton. We want them to do that too, but actually, you know, what can actually the GP practices do to support carers with their health and well-being? We're also revising the premium specification with GP practices and the CCG, and re-establishing quarterly monitoring in terms of carers' information that the GP practices collate. We're looking at developing a short video to present on the screens that they have in GP practices to encourage people to self-identify as a carer, as we know that quite a lot of people don't want to identify or don't know that they're a carer. And we understand that from the engagement we've been doing with carers. We're also looking at revising a content of awareness training that's facilitated by Carer Support Merton. And we're working with schools and the Trailblazer programs to identify young carers and develop support available. And those Trailblazer programs are the mental health support available within schools. Also in subgroup 1, we are looking at the statutory duty around carers assessments and the process and pathways around that. And there's been a number of workshops, and the guidance in terms of best practice for staff and professionals supporting carers is almost finished. And this will really hope to standardise practice across the different services like Adult Social Care, the Mental Health Trust, and organisations like Carer Support Merton and Merton Mencap. We're also reviewing all carers' information content across the key websites, which is quite a large task. We've already got some good information, but what we found when talking with carers is things aren't easy to find. So actually we want it to be as easy as possible to help carers navigate to the right services and support that they need and to know what's available. In subgroup 2, we're really focusing on the health and well-being of carers, and bearing in mind what I said earlier about COVID, this is a really important thing to get right. We hoped that we would be further along with implementing carers' emergency plans. This became a really crucial thing throughout the pandemic, and it caused a lot of anxiety and concern for carers locally. We wanted to implement carers cards last year. Unfortunately, because of resources, that's taken longer than hoped. But we still want to do this, and we're trying to take a more pragmatic approach to looking at different phases to implement those cards. Carer Support Merton and Merton Mencap are continuing to promote carers' emergency and contingency plans. And we had a workshop in Carers Week that Carer Support Merton did. We were also part of a pilot site nationally recently to look at carer contingencies across the ICS, which is really important going forward to make sure that actually wherever carer goes at a point of emergency, that they are well supported with that situation. Also in subgroup 2, this was quite a worrying thing really when we were doing the strategy, that carers said that some council processes caused them additional stress and anxiety. And we looked at parking as an issue, and actually, you know, we've come some way to supporting this with carer parking permits being much more promoted and advertised in the council. And we're working with our direct payments team to make that process easier for carers. We're also got a really exciting project where we're working together with Wideway Medical Practice to produce a specific health questionnaire designed for carers, because we know that carers just don't prioritise their own health needs. So we're trialling this questionnaire at the moment, and then we want to share that practice, share the evaluation and outcomes of that with other GP practice leads across the borough. We're also looking at what is available to support carers with their health and well-being, and we will be updating the websites and other support very soon. In subgroup 3, which looks at realising, releasing potential, we've worked really closely with partners like the libraries and other partners to ensure that there is support available to those carers to help with digital skills, because we know there's a lot of digital inequality with carers. Also, Merton Mencap have recently launched a video that they've created around promoting digital confidence, which is really good. It's a very short video. I'd recommend anyone watching that. Also mapping local learning development opportunities and working very closely with our carers who are employees of the council to make sure that we are promoting a carer-friendly work environment and looking at how we can make reasonable adjustments to support our working carers. In subgroup 4, we're looking at a life alongside caring and really involving carers much more in how we design and implement new services. And we've got carers involved in some of our commissioning projects, such as the Supported Living Framework and the LD Community Opportunities Framework. And going forward, it will be the Domiciliary Care Framework as well. We've also spent quite a lot of time mapping what the short breaks offer is to give carers respite across the system. So that's both children's social care, adult social care and wider, and making sure that carers know what they're entitled to, and continually promoting the use of carers discretionary grants, which we increased at the launch of the carer strategy last June, which has actually really seen an increase in assessments. There have been challenges. A lot of the challenges have come down to resources. There's been a significant increase in referrals, partly because of some of the raising awareness that we've been doing, which did cause some delays. We've provided some additional funding to help with this. We've also, as I've said earlier, there's been a delay to carers cards and maybe some of the website reviews. We have struggled sometimes to engage with all partners, and that's been difficult because there have been other priorities over the last 2 years, as you can imagine, but we're now seeing a lot more progress and commitment, particularly with the South West London CCG. We have seen some delays in progress around children's schools and families for young carers and parent carers, but I'm pleased to say children's schools and families have provided some additional funding to Carer Support Merton to do some particular work here, which has really proved very successful. And hopefully we'll be receiving some recommendations from that work very soon. It's also difficult for carer representatives to come to some of the subgroup meetings and attend regularly because they've got other priorities. So we're looking at how we can be more creative with talking with our carers, because we really want to make sure that this truly is a co-produced piece of work. It's time now to just hear from our partners, and if I can just pass over to Sally to say a few words, and then if Sally can pass over to Tracy and then back to me briefly. Thank you.
Hello. For those of you who don't know me, I'm Sally Burns. I'm a parent of 4, the eldest of whom has Down syndrome and a wide range of medical problems. I ran a carers group in Merton for many years, and I'm now part of the Adults First steering group. That's a Mencap group for carers of adults with a learning disability and or autism. I've been involved with the carers strategy since I think the summer of 2019, which seems a very long time ago now. And I actually spoke to this board at the end of 2020. Back then, I emphasised the enormous impact caring has had on both our physical and mental well-being. In both areas, family carers have worse health than the general population anyway. But of course, it also affects our ability to work and hence our income, and our chance of having a life beyond caring. And all these effects have been well documented in research, hence the need for the carers strategy. What's happened since then? Well, there's been the continuing impact of COVID. Not only have more people been thrown into a caring role, but it's also exacerbated all those underlying problems that were there anyway. It's caused extra loneliness and more stress due to often less services being available for the people we care for, and the worry of how to access healthcare safely for them or indeed ourselves. Plus, for people like me, the continued need to protect our very vulnerable relatives, which is why I can't be there in person tonight. According to national guidelines, I know extremely vulnerable people don't really exist anymore, but sadly we know in practice they do. So it's even more important to make more concrete progress in achieving the excellent aims of the carers strategy, both for the well-being of carers and to prevent an even higher call on resources if we can't go on caring. This work, as Heather said, has always involved lots of different organisations, which is one of its great strengths, I think, and it means we get a wide perspective when we have our task group discussions. But putting it into practice needs a joint effort too. Sadly, a lack of resources has been a real problem. There's a feeling that a lower priority is being given to carers, but there are so many other things to deal with. The health service has obviously been incredibly busy and going through yet another reorganisation. And the impact of all these factors mean that I have to say I am a little bit disappointed in the amount of progress we've made since I last spoke here. For example, as Heather said, we'd hoped to get carers cards up and running by the end of last year, but it simply hasn't proved possible. And this certainly isn't due to a lack of commitment by officers or those in the voluntary sector. There's excellent people working on this, just not enough of them or their time. Resources really do need to be increased if we're going to get things going in the right direction. On a brighter note, to give you a sort of carers perspective, I do think carers have had a real impact on this work, right from the initial engagement. But in the 4 task groups, we've got carers on all of them. And here's a few examples of how I think we've influenced things. In the task group that I co-chair, we've made sure the pilot health questionnaire we've drawn up for GPs to send out to family carers is both very short and in really plain English, because we know only too well how carers feel when they're landed with yet another questionnaire. In task group 3, carers have been able to describe from first-hand experience just how hard it can be to combine caring with work if employers aren't flexible. And again, from our experience, we've been able to itemise the sort of problems carers are having with the direct payment system. And there's quite a lot of them, I have to say, and it's crucial to get these sorted out if more people are going to be encouraged to use direct payments in future. When it comes to carer involvement in commissioning, we now have a group of carers set up to assist with drawing up a new framework for supported living. It's been really good to be involved right from the start of this project. One of the things that came out of our initial engagement work was how much family carers did want to have a say in the way services were commissioned and run. So this is a good example of progress. We're hoping that carer involvement will continue in the same way as this with the work on day activities. So in summary, I know there's been a lot of really good work going on across the 4 task groups. We've ploughed on and we have made some progress in most areas. But my worry is I'm not sure that apart from the carers who are directly involved in the work, other carers would have seen many concrete changes as yet. So I just want to reiterate how very important it is that this work is given the right priority by all involved and isn't allowed to slip down the agenda. Family carers have had an even tougher time than usual over the past few years. We make a massive contribution to the local economy in terms of saved expenditure, and we should never be taken for granted. In the blurb I wrote for the original strategy, I said how I'd seen previous efforts fail, but I had confidence that this time things would be different. I really hope I can retain that confidence and see more progress being made over the next year. Thank you, and over to Tracy.
Thank you.
And can you hear me? And for those of you that don't know me, I'm Tracy Waite and I am the CEO of Carer Support Merton. I feel extremely privileged to have been involved in the development of the carer strategy. And for me, it's one of the best co-produced pieces of work I think I've ever had the privilege of being involved in. I think as Sally and Heather have touched on, there have been those challenges though. Partnership work is hard. And particularly for us, we've been more involved in some of the challenges around young carers and around parent carers of children under 18. And again, all carers have been particularly affected by COVID. But children under 18, we know from one of the surveys of young people that the young inspectors undertook, young carers have been disproportionately affected. The survey, they did very well with that survey. They reached about 2,000 young people and picked up some really interesting information and useful information. About 100 people who took part in that survey actually disclosed that they were a young carer. And as I say, there was evidence they'd been disproportionately affected. But children's schools and families have recently, as Heather says, there's been a change of staffing. There is appropriate representation on all of the subgroups, and they have commissioned us to do some work with schools. And we've started working with schools because schools are where the universal service for young people, and we've started to look at schools, to look with them at their practice. This is research work at this stage, to identify needs, and to look at their practice and to look at the identification rates. We're quite early on in that work, but we expect that to be finished by the end of July, August. We're working at some pace, and we're doing more consultation with young carers and their parents. And from that, we're hoping to sort of refresh and have some more attainable targets that we can begin to work towards. I think one of the earliest things that is coming out of that work is that the identification rates of young carers in schools is going to be very low. And I think lower than other boroughs who have done this work, some other boroughs that have done this work. But for us, it gives us a starting point. We know where we need to start working with schools, because if carers aren't identified, how can they get the support that we're all talking about developing? So that's for young carers. For parent carers under 18, we're doing a very similar piece of work. Looking a little bit more at specific issues for them. And again, we're doing a lot of consultation with parent carers, and we're particularly looking at the pathway to assessment, because that is less well developed for parent carers than other kinds of carers. And again, assessments are really good tools for sitting down with a carer and really working out what's going well for them and where they need more support, and preventing them reaching crisis point. So we're going to be working on those things in the next over the next, and we expect that to be finished by August. So that's from me, and I just end up with saying it hasn't been without its challenges, but I'm extremely privileged to be involved with the implementation of such an active strategy. Thank you.
Thank you. You want
Just
to,
very quickly,
Heather?
because I'm just conscious of time. So really the recommendations while we're here today is for the Health and Wellbeing Board to review the priority outcomes and to determine whether there are any other priorities to be included in year 2, for us to look at assessing the impact of the strategy, and for members of the Health and Wellbeing Board to commit necessary resources to support the delivery of the priority outcomes for carers. And we will be, as I said, we will be seeking the views of more carers, including young carers and parent carers, to help shape these changes as we go through. Thank you ever so much, Chair.
Thank you. Are there any questions or comments? Mark.
First and foremost, thank you. It's a brilliant strategy.
Mark, would you mind introducing yourself?
Oh, sorry.
Because I
Hello,
think
I'm Mark
some people
Hillman. So
may-
I'm the locality executive for Merton and Wandsworth at South West London CCG. So congratulations. I think it's a great strategy, and I think it's really great that we've got GP identification in there. Because actually we do know that GPs come across many carers just in their day-to-day work. So I think that's going to be really important in the identification. One area I thought perhaps we could think about was about discharge from hospital. So often discharge from hospital, it's considered it's about getting people home as quickly as possible. But I think sometimes the carers can get lost in the flurry of activity and getting someone home. And I've just come from a meeting with Health Watch where actually they've done a bit of a survey in terms of discharge for carers and the impact on carers. So just maybe something that we could work on together going forward.
Absolutely, Mark. I think that's a really good idea. And it is something that we're picking up within our adult social care remit, but I think we can go wider than that. And certainly, be very interested to have a conversation about that.
Thank you. Dagmar.
Yeah, I wanted to also say a big thank you because it's hard work, and it's hard work to sticking at it. And I think we must stick at it. And I know we all are short of money. There's never enough. But I do think as a health and wellbeing partnership, we do have to take the comments really seriously, that without putting some adequate resource in, we cannot expect the delivery. So as a partnership, it's a plea for us all to rethink really craftily how we can mobilize resources to keep this going. So that's a challenge for, I think, all of us to look again behind the sofa.
Actually, that brings me on to a question that I was going to ask, because Sally talked about a lack of resources. And as the new kid on the block, I may not look like a kid, but that's how it feels. I'd like to know what allocation of resources there has been to this work. And we've heard about problems with staffing and specifically children's schools and families. Is the problem that we haven't allocated sufficient resources, or is the problem that there haven't been sufficient people to undertake the work that's required? John, would you like to comment on that? Sorry to put you on the spot, but that's your job, isn't it, to be put on the spot?
I'm John Morgan, Interim Director of Community and Housing. I think this is a very complex piece of work. It spans multiple agencies, including the voluntary sector, children's health, adult social care. It's bringing together lots of different bits of policy. I think that the departments are all also very busy. And that's not an excuse. It's just the situation we're in. What I think we should do is, I think that Mark, myself, and Jane should have a discussion outside of here about what extra resources would be needed. I think it is a staffing resource rather than a financial one, because officers are stretched. So I think the best thing to do is to have a discussion outside of here to see what resources are needed.
See, Sally, you just need to ask the right questions in the right place. And I can give you an undertaking that I will ask the officers to report back to me when they've had this meeting outside this meeting, and to keep me informed of progress. I work for a voluntary organisation that couldn't function without carers, and I recognise the value of them, and I think we should, as a local authority, do everything we can to encourage them, and you know that does involve resources, but the way we should be looking at this is not how much is this costing, but how much is it saving us, and what is the long-term costs of carers being unable to continue in that role. And it's my experience that that bill is considerably higher than finding some money in the here and now. So if you could keep me informed of the outcome of that. And thank you, Sally, for raising that very important question. Are there any other questions, or sorry, who can somebody tell me who's, oh, it's, sorry, the name is so small on my screen that I must bring my reading glasses along. Sorry, Brenda, you wanted to speak, and then and in the meantime, somebody could tell me who.
I just wanted to add that in my years in the health service anyway, which links to other things, there is planned early discharge. So if you do planned early discharge, we don't have to be scurrying at the last minute to get people out and in inappropriate ways, because some people haven't even got their keys or their neighbors haven't got it. And so if we can plan in advance, we actually save some money.
I can provide a response to that. The whole emphasis around Merton Carer strategy is around prevention. It's about talking to carers early and being much more planned with our work. So I think that's where actually the carer strategy really would help with some of that planned admission, planned discharge, not just for people who are going via adult social care, but for anyone, whatever pathway. So that's something very much we'll take on board, Brenda. And yeah, absolutely, it's very much about planning and being organised.
I'm still trying to find out. So it's Dr. Mohan Sekaram. I hope I've got your name correct. It's not a bad first attempt, and forgive me for not bringing my reading glasses. I've got glasses for driving and glasses for reading, and my wife is always telling me to take them with me, and I tend to take the glasses for driving, which is probably a good thing from a public health point of view, but the reading ones tend to get left behind. Anyway, over to you for your question.
Thank you, Chair. So I'm Mohan Sikh, I'm a GP at wider medical practice, also the social prescribing lead for Merton, and I fully support this strategy for carers. And I also want to sort of highlight the fact for the Health and Wellbeing Board that our role is not just looking after the unwell patients, but also well patients as well, and carers as well falls a big part of that, and that preventative offer. And we need to all advocate for carers as being a role, and actually what is a carer. And I think a lot of carers or informal carers don't know they're a carer until they get pointed out. So I don't think it needs to come from one resource. I think it comes from all of us. And I think with that, detection is a really key bit, and we've touched upon that. We know that 10% of carers or 10% of our population should be carers, and we're well short of that. And so, as it's been mentioned, if we don't know who they are, then we don't know what support to give them. So I think identifying the offer, I don't think it's just about funding though. I think it's also identifying what your assets are. And we've got lots of assets in Merton, and with my personalised care hat and social prescribing hat, we do know that they see a lot of vulnerable patients and individuals who they could also detect as carers, and they've started doing that as part of their everyday checks, but also across the whole patch, can they help and not just refer everyone to Merton, Care and Support Merton, because they'll get overruled. So I think it's all of our duty to identify, support, know what's around, and also get volunteers to support each other. So really do welcome this strategy. So just a comment, really, not really a question. Thank you.
Thank you for that comment. Are there any other, Mark, you wanted to add something?
I was just going to basically agree around the planning. We should be planning for discharge as we are admitted to hospital. Yeah. And actually too many times what happens is there's a list of people that we identified for discharge, but they're either not ready to go or the medicines aren't ready, et cetera, et cetera. So I think it really is key that we work with the trusts on some of their internal mechanisms as well to enable us to kind of make sure it's a good experience and a quality experience for people, not just a fast discharge.
Any other questions or comments? Okay, well, can I thank you for presenting this paper, and thank you to Sally and Tracy for their contributions, which is much appreciated and much valued, and I think it is important that we do find some resource, even if it's, you know, borrowing from Peter to pay Paul. But you know, things are tight, and you know, it's not easy, but I think we need to make this a priority for the reasons that I've explained earlier on. Thank you. So the next item is health in all policies, and is that Janish or Dagmar? I've got both.
So
down.
if I very briefly introduce and then hand over to Janish, is that all right? So dear Health and Wellbeing Board members, some of you might remember that health in all policies it was one of our commitments and topics quite a while ago. And it is really the right time now to refresh our approach. As we've heard, we come out of a pandemic and are in recovery. We have a new ambitious administration, and the NHS is about to turn into integrated care systems, again with an aspiration of improving health and well-being. So health and all policy as a framework that combines health and well-being, equity and sustainability is an approach that we very much recommend for the Health and Wellbeing Board to pick up again. And how we're proposing to do that, I'm handing over for Janish to talk you through.
Thank you, Dagmar. Good evening, councillors, colleagues. Just to build on what Dagmar's been saying, so health in all policies is a collaborative approach. It's about tackling all of those things that affect people's health, that fall outside of the realm of the health system, employment, transport, housing, education. So it's one of the ways in which we can address inequalities in life expectancy in Merton. And there are many solutions to these issues. Merton's been a long-standing supporter of health in all policies. This was reaffirmed in the health and wellbeing strategy. And what we're seeing with the worsening of health inequalities from COVID and the kind of concurrent challenge of climate change is that actually we probably need to start finding solutions that tackle all of these things at the same time, hence why we're proposing health in all policies with a linked focus on equity, sustainability and health. So what that means is that all of these things would be considered in every aspect of policy making. And this links with the Council's long-term ambitions and the long-term health and wellbeing strategy. So the first Health and All Policies Action Plan for Merton was published in 2016. We've been doing a stock take internally. There's been a lot of progress on that. I won't go into all of the detail, but we've seen the establishment of a Dementia Action Alliance, building relationships between partners, a focus on healthy workplace, particularly a draft local plan with health and well-being at its heart, a range of projects on air quality, such as leading the way for London on low emission for construction, and social value toolkits and the like for council procurement. We've been learning with some support from the LGA, who's provided us with an associate to help us develop our revised action plan. And really, we're proposing that this would be in two parts. So the first is about ways of working. There's a number of things that would need to come in under this, probably building on culture and relationships, the best use of data and evidence, external partnerships, so key role for our health partners, our voluntary sector partners, and how we think about return on investment across different sectors. And there's a number of example actions that we think might fall under this in the appendix, which I won't go into right now. As well as those ways of working, we think it's important to identify a small number of real priorities which cut across a number of stakeholders. So there's a number of things this might focus on, and really the proposal is that the first one of these trailblazers, as we might call them, would be around a borough of sport. So promoting active lifestyles across a wide range of citizens, making sure this is inclusive, preventing frailty, supporting healthy weight, and bringing people together through activity across the borough. Additional trailblazers could include things like the council levers, social value, the council's employment or investment, air quality, or even revitalizing high streets. And really the final list of trailblazers would need to be developed over the coming months. You'd probably want to pick some short-term wins, some long-term wins, and think about which things would need acting on early to generate benefits in 8 or 10 years' time. The public health team can support this with a small number of officers involved in this work. And really the role of the public health team, as we see it, is to hold the action plan, facilitate progress and action, building relationships and networks, and supporting those cross-council and external partnerships in embedding health in all policies. So this is an opportunity really to invite colleagues, partners, to think about their role as part of the Health and Wellbeing Board in delivering health and all policies across the borough. It's everyone's business. And so really the kind of ask of this paper is for any comments on the action plan that I've outlined so far. Just to round that off, I think there's a proposal to run an action plan in 3 phases. So the first 3 years until 2025, those early trailblazers and capturing the learning. The following 3 years, picking some different trailblazers and embedding that learning in those, and then building towards systematically making sure every decision takes into account health, equity, and sustainability. So the main resources required for the refresh of the action plan are staff time and engagement. But after that, we might want to think about resourcing key strategic projects. To give you an example, the Sport England local delivery pilots invested millions. In Calderdale, which has a population of around 200,000, they invested 2.65 million a year from Sport England to spend on physical activity over around 2 years. Clearly, a full workup of local investment would need to be undertaken, but that's something to consider in terms of how those trailblazers would get taken forward. As I mentioned, I won't go into the appendix in detail, but that detail is there if you'd like to see it. And the main recommendation is for any comments of the board on the revised Health and All Policies Action Plan. It's likely it'll take a few months of further conversations to refine those, but this is one such opportunity to comment. Thank you very much for your time and any comments.
Thank you. Any comments or questions? Mark, we can always rely on you. Thank you.
Sorry.
Good man.
I suppose just to really welcome the report, and actually we will welcome the initiatives, because I think actually when we're talking about integrated care and we're talking about the wider determinants of health, this is exactly what we should be partnering up on. So it was just to really lend from a health perspective support in ensuring that health and all policies we really get behind it together.
Okay, well, I'll ask a question then from the chair, and that is, how do we get this embedded into the different departments? And I mean, is there somebody within each department within the council who is responsible for spreading this good practice within that department and making sure that opportunities are not overlooked? Have we got champions? Have we established champions within each department to kind of get them engaged and get them asking questions of their colleagues and encouraging them and pestering them and badgering them and forcing them to do the right thing? who's best placed to answer that? Is that you, Dagmar?
Yeah, I can give it a go, because absolutely we're bringing it here to the board because the aspirations are laudable, but as you put your finger on, how are we actually going to turn it into reality? And therefore, for me, we quite explicitly said it's a part 1 and a part 2. You've heard today in the staff conference of the council quite a lot around the ambition and commitment to review the culture and how we are developing staff, keeping staff, recruiting staff. That is an anchor where we can start to plant this. Every induction, for example, for new members, every appraisal and review could have this embedded. We have got an learning and development function. Your idea about champions, initially going where the energy is, seeing who in the council is interested. It is very telling how much people get fired up if you particularly bringing the equity angle and the sustainability angle together. This is what people care about. You will have heard it today in the staff conference as well. So going where the energy is and working with champions, that's the part 1. But there is also real importance to do a committed part 2. So what is it? And for me, the borough of sports, so the big ambition of the leader and the administration of this council, lends themselves perfectly fine, making it inclusive, saying active Merton, because maybe not everybody is completely enthused by sport, but it would capture so many goals with one stone around equity, well-being and sustainability, that I would be really enthused now to work that up and have everybody pushing it through.
So has this been discussed by the corporate management team with a view to working out how this can become, instead of this is a good idea, if only we had the time, to this is a good idea, how do we make it happen? John?
It is regularly discussed by CMT, of course, but do remember as well, we have a number of directors here as well. It isn't just adult social care, community and housing. We've got the Director of Environment and Regeneration, who is a member of the board, plus the Director of Children's Schools and Families. So also as well, there is a role for Cabinet in here, because for Cabinet to push these policies through, every time that we're discussing things, we should be thinking about health and all policies, CMT, DMTs, all of it. So as Dagmar said, she'll take up and work out how we'll do the doing.
When there are proposals and papers coming forward, there's always a section that deals with the financial implications of something. Do we have a section on such reports that deals with this particular issue and how it might impact? That's a really simple thing to do to kind of get engagement and buy-in and get people thinking about it.
So the honest answer is that Chair, if I may.
Oh, sorry.
The honest answer is that a section on board papers can be a helpful prompt for people to think about these things, but isn't always the right answer, because sometimes people don't necessarily understand what's involved in one of those prompts, don't necessarily know how to fill those in. So it can prompt that thinking through a number of decisions, but from my experience of other such policy processes, doesn't quite solve the whole piece, so to speak.
So can we get this on the Cabinet agenda then? Brenda.
Thanks, Chair. I was just going to mention some of what John has said, because one of our cabinet member, Caroline Cooper Marbert, she's now cabinet member for sports. And so therefore we should link it. My remit We are talking about young people being involved and not just being told to do things, but be part of it. And it's not about sports alone, but the environment and the ecosystem, the whole gamut of it, really. So I think we need to sit down together and discuss who is doing what and when, and who is being involved. And then we might be able to sort out the money with Caroline Holland.
Yes, thank you very much. This is an excellent policy. And I was just thinking to tie it all together, it would work brilliantly with the climate action plan because it already has targets set. And obviously with the sports, is cycling and walking being active. So I think if you looked at the climate action plan, you've already got a plan there and targets and timescales and all of those. So maybe that's a way forward to how it could all tie together.
Mark?
This isn't a criticism, it's a compliment, because you're talking about internal departments. And I just wonder, in terms of the integrated care system, if we could also take it to the borough committee, because we've got a host of organisations, whether they be acute, the Mental Health Trust, that we could really kind of use that as a conduit into other organisations as well, so that we are beginning to join things up, and it's a good message, isn't it?
We've only done 2 weeks now, 2 Saturdays of walk and talk. And it all came because it's happening in Wimbledon. And now it's migrated to us. And people are really loving it. And we're wandering through places that we didn't even know existed. So we're learning, and I'm losing weight without having to worry about losing, which I wanted to. And we are a mixture of age groups and cultures. And the papers are out and it's on the system. We need to know how to tell people how to do this. And I am very linked with Dr. Mohan because he's in my area. Yes, he's handing up. So I know all about what he's been doing. And people are encouraged to do this. And Age UK, I'm also linked with them. I didn't say that, but I didn't think it would be a problem. And the age groups are different. And as I said, there are lots of cultures and they want to be involved. And we just need to publicize things a little bit more.
Glad you raised that, Brenda, because I've taken part in the Malden Hall Park walk and talk. When I was invited to attend, I thought that might be a bit challenging for a man to multitask, walk and talk. But I demonstrated that it could be done if you concentrate. But I also, when invited, pointed out that I'm part of an informal walk and talk, and have been for some time now, of a group of dog walkers who meet on Mitcham Common at 6 a.m. And if anyone would like to bring their dog and join us in that, they'd be very welcome. And we are a very mixed group, and the dogs have fun and they get their exercise, and the humans also have fun. And it's a great way to kind of get rid of the stress and keep fit and keep healthy, as you say. And we should encourage that. And it's so simple and easy to do. And I really applaud the work that Walk and Talk are doing. And my impression was that it's very popular, and I think it will take off, and we'll see more of it. And I look forward to meeting you from time to time on such walks. And you're welcome to join us on Mitcham Common any morning you like. Sorry, Dr. Mohan.
Thank you, Chair. I also want to highlight that this excellent policy and something we should all be adhering to. And was also going to mention the green social prescribing, which is the walk and talk. So it's about using our natural spaces, our natural parks, and we've got plenty of those in Merton, and we are using that with walk and talk, and some wonderful feedback. I think they had over 400 members walking around, which is just brilliant. I'd also want to highlight the other massive asset, Merton Can, so try 22 and 22, which is massive as well. And that's, again, two big schemes, which we all should be shouting about, something we're really proud about. And this feeds really well into the policy we've got. We've got it there, it's existed. And so we need to advocate it, get more people involved in it, and that's how we can grow our assets. So I don't think we necessarily need to look at something brand new, because it's here, it's there. Let's grow it, let's put some water on it and make it bigger. And yes, Brenda, I remember our walks a long time ago. Wideway Walkers, I think they were a few years ago. They've closed down now, but good to see that Walk and Talk is up and going. Thank you.
Thank you, Doctor. And I'm sure you'll be encouraging all your patients to participate, because you see the benefits to their health from such activities. So any more comments or questions? So have we given you enough of a steer at this stage? And I think if we can, I mean, Brenda, you were in the cabinet before. Again, I'm a recent addition. So has this been discussed previously, or is it something that needs to be?
This is the first time I'm actually discussing it so widely. But that was leisure and culture, and the leisure was mainly to do with swimming pools and libraries. But this is quite different. This is outdoors and free. And in fact, you're not obligated to come, as whenever you come when you want to. And in fact, when you do that to people, they come anyway. But if you start telling them to come at 10 o'clock, they'll think, oh, I can't get up then. And so the other, my other cabinet position didn't actually cover this. But this is also my
question was, when you were in the cabinet, regardless of your portfolio, was this ever discussed at the cabinet? Okay, well then maybe that's something that we need to arrange, and I'll have a word with the leader and see if we can get this on our agenda at some point. And that's a good start, isn't it? Okay, thank you. So are we done with this item? We've given you some thoughts and some
Thank you very much, Chair.
Thank you. Okay, so the next item is NHS and social care items, and we've got a number. So we're going to start with the Better Care Fund, and that's Annette. Is Annette with us?
Yes. Can you hear me okay?
We can.
Great. Thank you very much for that introduction. So my name's Annette Bunker. Clarissa's helpfully sharing the presentation slides here. This was pulled together jointly by myself and Phil Howell, Assistant Director at the Council. Unfortunately, fortunately for Phil, he's on annual leave at the moment, so he passes on his apologies. The Better Care Fund, it's a national policy framework, and it works around a single pool budget to incentivise the NHS and local government to work together more closely. The focus is wellbeing, and it's an opportunity for us to take part in joint initiatives to improve services for the local population. And there's ring-fence budgets around this, both from the CCG and from the council. Next slide, please. This is just a brief summary of the 21-22 fund. As you'll see, there's a contribution from the CCG. There's also the IBCF and the Disabled Facilities Grant. The latter two are funds that go directly to the council. Next slide, please. So the Better Care Fund and the plan around that is closely linked to the local health and care plan. And in terms of other work, we link very, very much in terms of the national strategies and the local strategies across the Health and Wellbeing Board and beyond. And particularly around the local strategies, the priorities are looking at, sorry, the next slide is fine, thank you. Around the local priorities and the national priorities, that's really where we focus the funding. So, I mean, the money is largely historical and it's spent on key community and social care services. But we also look at what the local initiatives are, where the priorities are in the local plan and the NHS plans to look at where we should be focusing our efforts for the coming years. Next slide, please. So the plan is jointly agreed, and as the Health and Wellbeing Board, that's the overall forum with which to agree the plan and how the funding's spent. And the funding is largely spent on maintaining social care, looking at NHS provision out of hospital, so that's mostly our community services, and then looking at managing transfers of care. So the focus of the work is largely about keeping people well at home, but if they need to go into hospital, then the idea is to avoid them deteriorating at hospital, to get them home as soon as they can so they can get back to their normal settings. Next slide, please. Thank you. As part of the planning process in 21-22, we had a series of metrics that we were asked to monitor our progress around some of the key aspects of care. And most of these were actually new for 21-22, except for the last two, which have been long established around permanent admissions to care homes and people who have reablement still being at home. So for the areas where the new areas, I think a number of these were challenging for us, particularly because of the pandemic, because of more complex, frailer patients coming through the hospital, but also because particularly over the winter period, there were a lot of challenges around staffing, both in terms of sickness and vacancies. So whilst we've done well on these, we haven't quite met the targets that we hoped we would. And we'll continue to look at how we can improve those in the coming years. Next slide, please. So the whole Better Care Fund arrangement is documented through a Section 75 agreement, and that's the contractual arrangement, if you like, between the CCG and the councils. So that details the arrangement of the pool budgets, and has various aspects to that. Next slide, please. So for me, anyway, the most interesting bit really is what we can do with this money. And there's been a number of key programmes that we've been able to set up and develop through the Better Care Fund over the years. So there's just a summary of them below. So the proactive care that takes place to support people in their own homes. We've got a multidisciplinary team in each GP practice in Merton, known as the Integrated Locality Team. So that's made up of many different agencies, and they support people to stay supported in their own homes. Then we also fund schemes to improve flow from hospital to the community, and then have schemes around intermediate care to support them getting back to where they were before. Rapid response services, which is around helping people avoid hospital if they don't need to go in. A whole programme on supporting care homes. And we've recently got a care home support team in place now. Work to reduce inequalities, so that's a key aspect of the work, as well as I mentioned before the Disabled Facilities Grant. That's used really to support all of those initiatives. So there is more detail around those individual schemes if you're interested, and because of the shortness of the time available to us today, that will get shared out in the papers and the minutes when you receive them. So hopefully you'll get a bit more of a flavour of some of the schemes through that. And just what I would add as well, if that's okay, is that that was the summary of the Better Care Fund in 21-22. We are hoping to get the guidance around the 22-23 spend shortly, and I would hope, but the timescales are out of our control largely, that we could put an update on the 22-23 position at your next meeting in September, if you're happy for that to take place.
Thank you. I've got a question, so if I can jump straight in and
Please
ask
do.
you to put a bit more flesh on the work to reduce inequalities. This is a priority for the new administration, and we really do want to see. We're always very pleased to hear warm words about tackling inequalities. We actually want to see some action. So perhaps you can tell us a little more about what you are doing in your work to reduce inequalities.
So one of the schemes that I mentioned at the beginning around the proactive care to support the vulnerable, there's a different layers to this. So some of that works to support vulnerable in their own homes. So some of that funding, for example, goes towards the social prescribing, which started in East Merton, is now across Merton to support those most vulnerable. As well as that, we've got this year we funded the Community Response Hub. So, I mean, that was something that was established during the start of the pandemic, but through the Better Care Fund, we've been able to maintain that. And it's focusing now on trying to access services to people who perhaps wouldn't normally, get that support. There's also the Living Well service that we've supported through the Better Care Fund, which is run by Age UK, and that supports people that are perhaps not necessarily in need of health services, but they're in need of support at home to look at how they can manage their lives better. And there's things like reducing isolation as well amongst older men. So there's a small amount of money goes into this music workshop, which is called Tuned In. And as well as that, this funding also supports.
I have sort of sprung this on you, and you did say that you'd be happy to bring back a report.
Have I gone on too long?
No, what I'm saying is, if I say, could you come back next time with a kind of a report on that, perhaps a written report in advance that we could have a look at and see what efforts you're making and what initiatives you're taking in this area, because it is something that we are all very keen to see progress made in.
I'd be happy to do that. So if you're happy for me to, well, it'll be probably a double act with Phil, if you'd be happy for us to put the proposals around the 22-23 plans, and then we'll put a particular focus on what we're doing to address inequalities. Does that sound okay?
Welcome. Thank you.
Great, thank you.
I asked my question. Are there any others? Sorry, forgive me for not knowing your name.
I'm Vasa, I'm a GP. I belong to a practice which is part of modern PCN. And Annette knows me for years because frailty has been something close to my heart, because a lot of my patients are actually frail. The BCF has really done years of good work with this particular cohort of people who needed this support. And only one criticism: we actually don't explain and sell admission prevention adequately at public events, because we call it the wrong thing. We call it admission prevention, and therefore we give it a negative connotation. The truth is that people who are frail and people who are unwell, whatever reason, when they go to hospital, we all know they come back deconditioned and they come back unstable. You may cure the pneumonia, you may cure the UTI. If you define them as chest infection and kidney infection, yeah, you're done very well. But if you define them as a person, which you should, they don't do very well at all. They come back, every carer knows this, everyone who looks after frail people know this, they come back deconditioned, unable to function as much as they did before they went in. So we should not call it admission prevention. We should really be calling it deconditioning prevention, because if we called it what it is, then we'll actually sell it better, and carers come into the picture. So when we want to keep someone at home to look after them, to prevent them getting deconditioned, we rely a lot on the carers, and their equality comes in, because if you have your social capital, if you have your financial capital, if you have capital behind you, you're able to support that person better to stay out of hospital. If you don't have the social capital or the financial capital, the network, which is not finance, it's more actually a social network. If you had one, that prevents you going in. In fact, if you had a good social network, it catches it at the level of a urinary infection before it becomes a kidney infection, which puts you in. So we really need to sell this and understand this better, so that I'm not putting a positive spin. I hate positive spinning. I'm not putting a positive spin on it. I really want the truth to be known about the importance of supporting people in the community before they go in, and also obviously supporting them when they come out. So a lot of your work, Annette, I can help you prepare your report to show how much equality comes in. We don't flag it up, but I think we should verbalize it, so that people understand this better, and we all get behind the BCF more than we currently do, because it does such good service. It adds real value to people's lives.
Annette, do you want to come back to that?
I totally agree with Vasa, and would very much welcome his input into any of the future reports. I think that a lot of the work we do in the Better Care Fund does help keep people at home, but I still think there's a lot more work we can do to support that. So thank you for highlighting it.
Thank you. Any other comments? Brenda?
I'm not sure. I don't even think this is a question as such, but since I've been here 2010 till now, we've been talking about hard to reach people. And I'm still trying to find out if we know who these hard to reach people are and why are we not reaching them. So I just wondered, Annette, if that's going to be part of your inequality discussion.
I think Vasa wants to come straight back on
Chair.
that.
Chair, you touch a nerve.
Yeah, well,
Chair,
you were like a greyhound coming out of a trap.
yes, it was, because you touched a nerve. Because I have tried very hard in the last 2 years in particular to try and say, let's not say hard to reach, because the people are not hard to reach. It's we who are hard to reach. And I think we actually passing the buck by saying someone else is hard to reach. I think in our forum, we should be saying, how can we make it easier for people to reach us? So they're not hiding. They are there where they are for a reason. I'm not seeing them or hearing them. So in fact, we need to consider whether it is the vaccination program or active living program or health prevention program, whatever agenda we have, we got to work out, because you know what, when the vaccine came along, we did work hard to go and reach everybody and anybody, anywhere and everywhere. So we got to learn from that, translate that. If something is important, as it was in the vaccine program, Mohan and I, we made lots of effort. But before that, Mohan more than me, he did venture out more than I have in the past, but we all have to venture out so that this business of somebody being hard to reach, I think we should try and vote to say that word should not be permitted from any officer or any doctor coming to this event here to talk to you about it. Because by categorizing as such, we are actually leaving them behind. If we don't use that word, we'll be more inclusive.
I was quite pleased to see proactive rather than reactive, but it's exactly what you're saying, Dr. Vasa. If we keep asking it to somebody else to do, and you were the chair when I sat on those health panels, and we've discussed it for all these years, and still keep saying people are hard to reach. If we never reach them, we will have more problems in our society, because they don't know if they're ill, we don't know where they are, and we just wonder what we're doing, really, to be honest.
Vasa, I think what you're saying is we don't want to be hearing hard to reach. We want to be hearing how we reached all members of our community and sharing that best practice. Okay, so have we agreed to ban the phrase hard to reach? Is that unanimously agreed? We will not hear that, and that will not be included in any future reports. Mark.
It's just in terms of the bringing the paper back, because I think what we have within this presentation is we've got kind of high level titles of initiatives, haven't we? And actually it's really important that we dig beneath the data and actually we look at where and who the people that are accessing these services are, and that we use the BCF as a place to direct the resources. So if we identify by that analysis that there's a gap, then actually we shift the resource to enable that gap to be filled. And I think that's a really important thing for us to think about when we're considering the BCF, and use it more as a tool for our next intervention. Thank you.
That could include who have we failed to reach and what are we going to do about it? Okay. Thank you. Annette, do you want to comment on anything?
I totally agree with that, and I think that was really helpful to guide what we should be prioritising for 22-23 and what we should be presenting to the next meeting. So thank you.
I think taking up Mark's point, that should include some kind of mapping of where we are and where these activities are taking place.
Yes, I'm not sure what data we've got around that, but I'll do everything we can to see what we can pull together to make that a bit more straightforward for you to review.
Okay, well, let's have a go, and if it's not good enough, then we'll soon let you know. Thank you.
Thank you.
Mohan, I'm turning this way and that way and missing the little yellow hand up. Forgive me.
Thank you, Chair. Sorry, I'm going to bring up the hard to reach. I was also a greyhound out of the blocks, but you probably didn't see my hand. And actually, I agree with all that's been said. And I think what vaccine uptake has told us that we've gone out to reach these people, but we've not actually reached them in a way which they understand and they don't want to be met or reached, and therefore we've been knocking on doors in Pollard's Hill and they've been saying, look, I know you're there, go away, don't listen. And so we actually need to reach them in a way that they understand, we speak their language, we understand what their needs are, otherwise we will continue to not be able to support them as best we can. So yeah, so that's just, I wanted to add that really, but thanks.
Thank you. Well, maybe when it comes to learning how to reach people, we can learn from your experience and that of Vasa's. Simon, your hand is up.
Yes, thank you, Chair. Simon Shimmons from Merton Connected. I was just going to build on the point that Vasa made and Mohan, but we do have 3 initiatives that are very successful and growing at the moment. We have, I believe, over 160 community champions who are helping to support health messages. They get regular updates from the London Borough Merton Health team. We've recently just been helping to set up specific vaccination champions, but that's not just about vaccinations. That's moving into things like winter flu, as unfortunately we'll get to as we go. And we've also, from a Merton Connected point of view, we're supporting Core 20 Connectors, as they're called, which is a sort of central NHS drive that's being pushed nationally. So we've got 3 different strands of people that are specifically trying to represent both the concerns, because as Vasa said, it's not about hard to reach, it's about making sure that the messages are appropriate and any sort of cultural heritage points are taken into consideration in the way that those messages put forward. So I think as a borough, we've got a lot of activity that is actually pushing, trying to push those messages, in appropriate languages, in appropriate sort of cultural context, to try and help people realise the support that Vasa, Mohan and the other health professionals can provide at community level. Thanks, Chair.
Thank you. Any other comments or questions? Okay, well, thank you for that, Annette. And now we're going to look at the health and care plan, and Gemma is presenting that.
Thanks very much.
Hi, sorry, clear my voice. Hi, good evening, everybody. My name is Gemma Dawson, and I work on Merton Health and Care Together programme. Hopefully Clarissa has some slides that she's able to share with everybody. Fantastic. Just like magic. If you could just switch to the first slide, that would be great. Great. So the Merton Health and Care Plan identifies health issues which require health, social care and the voluntary and community sector to work in partnership to improve the health and well-being of our residents, particularly addressing health inequalities. This plan is a refresh. It will replace a plan that we have had in place from 2019 to 2021, and it builds on some of the learning and experience from delivering the first 2 years of delivering that Merton Local Health and Care Plan. So this new plan starts just this financial year, and across all of the aims of this plan, we've got kind of 4 broad aims, mainly to reduce health inequalities and embed equity, to use our population health management approach to drive change. And by that, we mean making sure that we're evidence-based and that we're looking at the data and information at a population level, so that we can make sure we're targeting our efforts to make sure we're putting our resources and our energy in the right places to make the changes that we want. We want to focus on sustainability and making Merton a healthy place, to make sure that it's got the conditions for everybody to thrive. And through everything that we do in this plan, we want to engage with service users, patients, people who use our services and the communities that we serve, to make sure that all the work and the projects are developed alongside and in partnership with and by the people in Merton. The plan is builds on the success of our previous plan and takes a life course approach. So we identify areas around start well, so loosely at the beginning of your life, live well and age well. It's a mix of focusing on specific issues, so targeting in on an area that we need to do, and then some broader stuff around improving access to and information on services, and to try and change how people access their services. And I think that's quite an important point, and it particularly speaks to the conversation that you just had around tackling health inequalities, and also trying to make sure that our services are accessible to everybody in the community, and to understand why some people may not be accessing particularly our early intervention or prevention services, and perhaps not getting the care and support that they need in the same way that others can. And I think that really this plan is a vehicle for us to try and to take that on board and to turn that into action, just as you said, Chair, so that we can try and change and explore different ways of our services being accessible, particularly to those who need them the most. If you could switch to the next slide, Chris, that'd be great. So this just tries to give you a snapshot of some of the projects that we've got underway that to deliver our objectives in the plan over this next financial year. As you can see, they are identified under Start Well, Live Well and Age Well. And I've just done a quick sort of summary of the sort of high level outcomes that we are trying to go for by delivering these projects. So I think if I could just pull out a couple of examples just to kind of highlight those points and bring it to life for you. So across Start Well, we're really wanting to be focused on mental health and well-being, particularly to try and explore changing how people can access services to improve access so that more people, particularly children, their carers and their family, can have more access to mental health services preventatively. We're looking at exploring and pushing on some of our focusing on delivering our healthy child, I can never get these words out, the Child Healthy Way Action Plan, and particularly looking at expanding some of our successful social prescribing for children to help them support their weight management. And again, that's sort of picking up on some of our obesity, and we're targeting those areas where we know there are inequalities, because that issue doesn't affect all of our communities in the same way. In Live Well, again, you can see this continuing theme about how we're exploring opportunities to change how people access health and wellbeing services. We're starting a really exciting Health on the High Street project, which is looking at changing and bringing health initiatives into either the fixed locations of our seven libraries across the borough, working in partnership with our local authority colleagues to bring particularly children and young people's mental health services into the beginning access and publicity in the beginning of the libraries, so that children can access and talk to people about some of their anxieties or their worries in the library areas. So moving it away from mental health service areas, potentially there may be stigmas. And now we're also looking at exploring pop-up sites on the high street to bring health services out, particularly some of our existing health services around screening and around access for blood pressure and community health clinics into the high street settings. We've also got lots of projects down at local levels, working with our GP practices, particularly looking again at offering different and new ways of people to access information and advice, particularly for people who might be at risk of diabetes or just newly diagnosed with diabetes, connecting them up with others in sort of within their community and giving them access to experts and to ask questions through group consultations run at their local GP practice or in community settings. We're also doing a similar initiative with new parents and mothers around helping them support them through those first few months of raising a young child. Again, giving them access to existing advice and support, but through a group consultation model. So changing up how we're doing it, and particularly targeting groups that we know perhaps are not already accessing our existing offers. And then across Age Well, we're again being focused on frailty, continuing some of the work that was mentioned previously by Vasa and Annette, but trying to join up and connect so that we can make sure we're giving everybody a holistic approach. And again, picking up on some of the inequalities, particularly around social isolation and digital inequalities that some parts of our community might face. So looking at how we can make sure information is accessible and trying to really understand how we do that, and trying to change it so that we can reduce some of those barriers that people might have to accessing the health and care services that they need. If you could switch to the next slide, please. As I said, with this slide really picks on how as we're developing our plans and putting them in, making sure that we're being informed by the data and the needs of our people so that we can make sure our activities are targeted where they're most needed. So here we're being mostly informed by our Merton story. So all of the information and statistics from a joint strategic needs assessment that was published last year as a part of the refresh, and also from our new NHS Core 20 analysis, which is looking at the 20% of our population that are in the most deprived brackets, and looking at some of the health issues and understanding what it is to be in those groups. So this is just giving a bit of a flavour of some of that high level ideas. So we can see that we need to target right down to where, so the geographical ward, where to make sure that we're putting those through. If you could go to the next slide, please. And so this table really tries to sort of show how we're trying to map against and continually cross-reference to check that our initiatives and our activities are picking up on those health inequalities that our data and our analysis is pointing us to make sure that we are picking up on those and that we can continually be giving ourselves a litmus test that are we doing enough? Do we need to change? Do we need to iterate and add more? I think it's worth noting that our plan, although it's now officially started in our implementation from April, it remains dynamic. We want to constantly be refreshing and looking at it and changing and making and checking in with our communities and the people we serve to see if it's working, see if we want to change and do something different to add in. I think I'll have got lots more slides with just lots more details of all of our initiatives, the outcomes, and what we're expecting to do and our plans going forward. But really just wanted to give a flavour to the Health and Wellbeing Board on our approach. And really to underline the point that we are focusing on the strengths and the assets of our borough, to share good practice and to really focus on trying to make a difference collaboratively through this programme. If there's any questions, I'll stop there.
Thank you. Are there any questions? Mark.
It's just to say that Core 20 is probably a new concept, and we will come back to the Health and Wellbeing Board with more analysis of the Core 20 data. What we have to ensure is that that data is absolutely lined with our JSNA, so that we've got one data kind of source across health and social care that we're all working to. But actually it is the JSNA, etc., that is driving our local health and care plan. And just as an example, the mental health, we know that Black men are more likely to end up in acute mental health care. That's exactly why we've got an initiative there around adult mental health. So I think, and we have given you a lot of information, but we just wanted to make sure that kind of like we were highlighting the breadth of the work that was doing, but also it's quite ambitious and we need to make sure that we're kind of completely focused on it.
Well, there is a lot of information here, and what is Core 20? Can somebody explain that to me? And what was that? You just said GSNA, did you? Right. Okay. It's just that if people talk to me in letters, you know, I had a conversation earlier on and I thought they were talking about the Office of the Public Guardian, and what was it we were talking about at the time?
The Operational Procurement Group. Sorry for that. So hands up, no abbreviations. So the Joint Strategic Needs Assessment, for some of us, we were in overview and scrutiny yesterday, so I did talk about it. It's the statutory duty of the Health and Wellbeing Board, and it is precisely what Mark says. It tries to digest all the data and information that is available for a locality like Merton to help us have a common understanding of their needs, but also the assets. And Core 20, and it's indeed called Core 20+5, is now the data initiative of the NHS to identify the cohort of people in a locality that falls into the 20% most deprived areas. So that is Core 20. And it is an attempt to describe through data deprivation in order to focus delivery of services to those who most need it. Absolutely referring to the discussion we had before, they're not hard to reach. We need to stretch to find them. And we need to be aware, as you said, Chair, that when we deliver services, we generally look at how many people have benefited, 70% uptake, 80% uptake. We never actually or hardly ever say, well, who are the 20%? Who are they that are not taking up our services? And that is the push for all of us to use our data and intelligence better. And Core 20 is one approach that we will share with you. I think we're planning for September anyway, a more general session for the Health and Wellbeing Board around health inequality, and I think it lends itself to be picked up there.
That would be absolutely splendid. And if people can use words rather than letters, that would be helpful, particularly for those of us who are still getting to grips with our new responsibilities. And can I ask, while I've got the floor, if you don't mind, Jennifer, I have seen you. I don't want you to get a sore arm. But it says here under Core 20 on one of the sides, 67% most likely to be diagnosed. So Core 20 population are 67% most likely to be diagnosed with a mental health condition. Can somebody explain that perhaps? What does that mean?
It basically means that if you're in one of the geographic deprived areas, that you are more likely to be diagnosed with a mental health condition. The thing about the Joint Strategic Needs Assessment and the Core 20 is that I do think we need a proper session on it so that we can really establish it, because you get into the data and it's the analysis of the data and the intervention that then makes you do that's the really important thing. But actually we could, I can certainly circulate kind of some of our Core 20 highlights to you outside of the meeting. Happy to do that.
But I still don't understand what 67% more likely, what most likely, what does that actually mean?
So the analysis is, so it breaks it down to within the top, the Core 20%, yeah. It breaks that down to say that actually within Black and ethnic minority populations, 3 in 10, and I'm making the numbers up at the moment, 4 in 10 are more likely to be in deprived areas. You compare that to the white population, and it will say that maybe 1 in 10 are likely to live in the deprived areas. If you then say around mental health, it will say that actually the populations within Black and minority ethnic are 67 times, so it's a calculation there, but what they're actually saying is 6 out of 10 are more likely to suffer from, have a diagnosis of mental health than in the white communities. You're perhaps 2 in 10 are more likely to have a diagnosis. So it is a comparative number that we can then go on and explain in more depth across not just mental health, long-term conditions. We've got numbers on coronary heart disease, asthma, COPD, etc., etc. Yes, we were just kind of introducing it here today. Does that make sense?
It will when you do the longer presentation, and I look forward to that. And yeah. I really want to emphasize that health inequalities is something that, you know, really drives our agenda as an administration, and we don't want to, you know, it is something when you look at the you know, the difference in life expectancy between the east and the west of the borough, that cannot be allowed to continue, and we can't be talking about it. We need to be doing something about it, and I know that there are members of this committee who've raised this point previously, as I understand it. Even though I wasn't here, I have been reliably informed that there are people that have been pushing that agenda, and it is something that we want to address very seriously, and there will be a relentless pursuit of this and a desire to see what progress we are making on a very regular basis. So I look forward to that, Jennifer.
So looking at the focus on the health inequalities and the base 20 down to ward scale, I think it'd be very useful if that information could be shared with councillors. So when out talking to residents and have a knowledge of what those issues are and maybe be able to help.
Any reason why that can't be shared with members?
No, so we can absolutely circulate. Now, the one thing that I would say is that Core 20, we've had our first set of slides. It was presented to us at Merton, myself and Dagmar, and John said, well, actually, we think that actually you've missed a pocket of deprivation here, or actually we think this ward you need to go away and look at. So certainly what we will continue to do is kind of challenge the data as well. But we'll happily share what we've got so far. I think I welcome the focus on inequalities. And I think the really important thing as well is that with the Joint Strategic Needs Assessment and with the Core 20 data, we should be able to go down to not just ward level, but street level to actually really look at, you know, the gentleman that lives in Pollard's Hill that's got 4 long-term conditions. We'll be able to extract some of that information and then try to design kind of individual care packages around people. So I think it will be a really important kind of dimension that we look at going forward.
Okay. And my assumption, at the risk of labouring a point that I have been banging on about for a while, is there'll be lots of Core 20 people living in and around the current site of St Helier Hospital. You get my drift.
I get your drift. Yeah.
Good. Brenda.
Just add something to what Jennifer said. We all had the maps of all our wards, and they break it down into demography and all the rest of it. So that's something, if when we go and knock on doors, not necessarily election time, because we don't have time to go through all that, but we have meetings at least once a month or every 2 months. We could actually explain that to the people that we have. And I'm sure it would eventually sink in to what we are actually saying. But instead, we have it on the system, and most people don't go on the system anyway. So that's something that we could do.
I'm hearing is there needs to be some refinement of this data before we circulate it. And if colleagues need a bit more time to get it right, then let's give them that. But we will have a presentation here next time that will hopefully enable us to say, here's the information, and encourage colleagues to make use of it. And you know, they can then put their shoulder to the wheel in terms of addressing these issues. Dagmar.
Very briefly, as I said yesterday as well, understanding the needs of our population is an ongoing process. So the approach with Core 20, looking at the 20% most deprived population, is just one example of a new approach. Councillor Fraser mentioned our very well-established ward profiles. They are under the JSNA umbrella on the website now to be used. And we will then develop our understanding of Core 20 and will update the ward profiles once we understood the data. That's how hopefully nobody is empty-handed now, but we are constantly improving our understanding.
Navasa, you've had your mic on for a while, so I'm sorry I've kept you waiting.
No problem. I'm really happy to come after Dagmar spoke, because I think Dagmar is quite right. Core 20+Y is one lens, JSNA is another lens, and public health has got multiple lenses. We've got to bring all together, otherwise we'll mix the whole picture. And by the time you feature in the core 20+5, the horse is already bolted. You already had 3 or 4 long-term conditions and depression on top of that, which is also long-term conditions. So really what we should be looking at is not at that data. We need to look at data and hold ourselves responsible to say, how do we prevent people joining into that statistic? Because that's the point of saying 5 out of 10 people in Pollard Seal have a particular problem and only 2 out of 10 people in Lower Modern Lane have that problem. We need to work out the health determinants of health and the social determinants of health. And sadly, the social determinants of health far outweigh what health can do to improve health. And then we need to look into that, whether it's employment, whether it's education, whether it's housing, whether it is green space, whatever it may be. We have to walk the walk, because the way you prevent harm happening to the people who belong to the core 20 is not by more doctors, it's not by more medication, it's not by more nurses. It is by actually the social intervention of education, employment. Health literacy is a word we hardly use, Dagmar, but it's a word we should not be ashamed to talk about. Literacy doesn't improve your health. Health literacy can improve your health, and we need to verbalize that concept more than what we currently do, so that we help the people who currently are part of the statistics of the core 20+5. Otherwise, they'll always remain there, because Dagmar has never given up on the word prevention. We should not use the word prevention, Dagmar, because when you use the word prevention, we make it something special, something bolt on, something additional. That should become mandatory when we talk about health, because there's no point talking about health in the perspective of disease, which we all champions are doing. We really need to talk about health, much more about prevention of disease happening, so that people don't suffer. Because by the time you become diseased, you're a patient, you're suffering, then I get involved. That is really, really wrong. That's the horse is already bolted. So I think we should use core 20+5 Dagmar to improve our prevention agenda. And in everything we do, we want to achieve equality, we have to achieve prevention. If you can't achieve prevention, you can't achieve equality, because damage has happened. And this, sadly, doesn't start at 25 or 45 or 55. This starts in your early years of life. That determines a lot of your education and your health and your empowerment, your confidence, your self-esteem, your value, all that, but 0 to 5. And that's what the evidence is. And that's what we should be going. Otherwise, what we'll do is we look at core 20+5 and start talking about diabetes. That is an absolute, nothing wrong with it. I like it because I do it, but that is the health model. But Dagmar will tell you the psychosocial model of this is early childhood and preschool, what we call adverse childhood events. Adverse childhood events lead to long-term conditions, lead to mental illness, lead to a lot of harm, which we then multiplies. Dagmar, do you want to ratify what I said from a scientific point of view? I'm just a GP.
Don't underestimate the power of GPs. Anecdotal story. My mother stopped smoking when her GP looked her in the eye and said, in very plain language, if you don't stop smoking, it will kill you. And she stopped. I just wished that somebody had had the courage or the initiative to say that 20 years or 40 years earlier, because the last few years of her life were an absolute misery. And she had COPD and all sorts of associated health things that, you know, and why didn't somebody take that step? So please, whenever you get the chance to one of your patients, even if you think they might snap back at you, please keep going, please keep trying, because too many people die from smoking related diseases. We all know that, and we all need to tackle it.
Right. I must declare, I am a past midwife, and on the board we saw about early years, but early years doesn't start when you're born. It starts long before that, at conception. And from what I understand, during COVID time, lots of women didn't get any help at all because they didn't have midwives, or the midwives were a bit worried, and everybody wearing a mask and rushing around scared from everybody. And so we had lots of deaths, especially with BME mothers. And so I taught health for a very long time, and childcare. And as I said to my student, we're not starting with the baby, we're starting before that. Never mind what the program says, we're going to start before that. Because if mothers are healthy and they're getting proper treatment, we're likely to get healthy babies. Whereas otherwise, we might even not even have the babies because they die in early birth. So I think we need to review where we start.
Thank you, Brendan. That's a really important point. So are there any other comments, questions? Well, Gemma, thank you. And we've got some further discussions to take place. And I hope we've stimulated some thoughts about where we take this and how we want to look at it again very soon. So item C is Epsom and St Helier update, and item D is the East Merton Model and Wilson Hospital. And Mark, you have drawn the short straw on that one, so over to you.
So I am aware of the time, so I won't go through slide by slide, but just to say that the proposals around Epsom and St Helier is around consolidation, particularly around specialist emergency care. 85% of the people who do need the care will still be seen at Epsom and St Helier. And there would also be 2 24 hours a day, 365 urgent treatment centres. There's going to be £80 million spent on refurbing both Epsom and St Helier, and we do know that the current site and the current estate is just not fit for purpose. Next slide, please, Clarissa.
Mark, can I ask when that money is going to be spent? Are we talking about at some point in the future, or are we talking about this year?
You asked in terms of the update. So I asked the program team at Epsom earlier, and the main feedback is we're waiting for the hospital programs to then tell us what the next steps are. Now, the Epsom and St Helier team are lobbying on 2 fronts, really to maximise the money that they're getting out of the programme, but also with the release of early funding so that they could get on with planning, get on with the kind of the planning submissions, etc., and then get on with the build. But as the slides say, we're now looking at a delay in terms of 2027 at the earliest. And I think Epsom and St Helier, the staff, the senior managers, etc., think that staff and patients do deserve better than that. So the Trust is making a really strong case to the national programme for upfront investment, and part of that is part of the 80 million to do some of the refurbishment. The Trust continues to strive for safe and secure services. So although we want to ensure that the site is refurbished, we also want to make sure that people are assured that current services are safe and clinically appropriate. So we wanted to make sure of that. The update, I think, will probably be disappointing to the chair and to Merton as a local authority. And what we did agree last night is that the Overview and Scrutiny Committee would take a fuller update at the September meeting. And what I was going to suggest was that that actually the Overview and Scrutiny Committee take the update and do exactly that, scrutinise it. And then for us at the Health and Wellbeing Board, is that there have been a number of health inequalities reports written about Epsom and St Helier, and they recommend action at primary and community settings. They recommend action in geographies. And I was wondering perhaps that the Health and Wellbeing Board receive a report back from myself at the next meeting on those actions and where we're standing in those actions. Many of it Gemma has touched upon, so there's plans in place around particular areas, but it does go back to actually some of the inequalities and the mitigations that people like the King's report said you would have to make to ensure that health inequalities were mitigated across Merton and indeed Sutton. So I suppose that's within the capsule of the 4 slides that I've given you. It's basically that there's lobbying going on at the national level to try and free up the money and make the money come quicker. We know that there's delays. We have to ensure that actually there's an interim plan for both hospitals, and then also make sure that we're addressing the inequalities that the health, the King's Fund, amongst other reports, have highlighted for us. So that was going to be my suggestion to you, Chair.
Delighted to hear your suggestion, but I mean, you've not referred to the reports in the Health Service Journal that the funding for the new hospital has been cut from 500 million to 400 million. I regard the Health Service Journal as a reputable source of information. And there's also a report that the initial funding for the sort of setting the work in motion has been cut as well, and that's produced a delay of up to 2 years. So it makes it even more important that the substandard provision of health services to the people that use St Helier, who are from the most deprived area and in you know, the category of the what's the term, the 20, those people deserve better and have not been provided with an adequate service for years. There's been a blight up there, and you know, these multiple attempts to try and move the hospital away or move A&E and maternity services away from St Helier has led to an investment blight, and it's wrong, and it exacerbates inequality that the people that I represent in South East Merton have suffered for so long and appear to be continuing to suffer going forward. And I will not be quiet about that, because I've been elected with a mandate to speak up on their behalf. They are people that need strong voices to be raised when equality is being exacerbated by people with very little lived experience of what they put up with, including the fact that many of these people do not have access to their own transport, and yet they're being expected to travel to Belmont, the other side of Sutton, to access, and the idea that that doesn't matter and doesn't make health inequalities worse sounds to me like a very middle class approach to it, because people that have got access to their own transport, it's very easy for them to say that. Try getting on 2 buses when you are elderly and you are deprived and you've got long-term conditions and you are struggling to have your health needs met.
So I don't disagree with anything that you've just said. I think in terms of the Health Services Journal, the national programme is yet to confirm. So we've been asking, or the programme have been asking for the national programme to confirm levels of funding and also dates of funding. And that's one of the outstanding things that they're lobbying for. I think in terms of travel, there are travel travel plans within the programme about working alongside our LTR and the transport system to enable easier access, particularly for those that can, that they need to use public transport. But again, I do think that's probably something to bring to the OSC in terms of where those discussions have got to, so that the Merton OSC are being provided with assurance that some of these issues, we know parking, we know traffic, we know public transport, were all raised previously, and we should have and the programme should report back on the progress they've made on that. So hence the conversation last night to the OSC.
Does anyone else want to have any questions or comments to make on this issue?
Probably I'll just say that I support what you're saying, because I've been there, standing outside picketing, doing everything, and all over the borough, and in fact getting nowhere. And a lot of people do want to keep St Helier alive, but we've taken it down to really almost destructive. The place is falling apart in most places, in most parts of the hospital. But at the same time, I don't think many people around here wants to go to Belmont. Epsom, I had my knee down there, and I quite like the care, but some of the places were prefab buildings. So we need to look at if we're talking about inequality, we shouldn't be dividing up what should be equal and what shouldn't be equal. And I think that's why we're so passionate about St. Helier Hospital.
There is a real sense in the east of Merton that the views clearly expressed in the consultation, overwhelmingly expressed, have been ignored. And I've attended most of those consultation meetings. And yes, I have been in touch with the Secretary of State. And somebody said recently that, well, this has all been settled because the Secretary of State made a decision. Well, you know, I have to say that the Secretary of State, Matt Hancock, made all sorts of decisions whilst he was in office, some of which involve favours for friends, has been reported in the press. You know, there are all manner of criticisms, but, you know, the people that we represent feel that they have been very badly treated and let down by the NHS for decades, and that this proposal is wrong, and we will continue to articulate that view as long as it takes, and you know, and we will oppose what has been proposed because we think it damages their health and it increases health inequalities. Okay, anyone want to add anything? And what about the East Merton model and the Wilson Hospital, Mark?
Apologies. So just in terms of the East Merton, last year, autumn of last year, we were able to identify NHS funding to basically, and I appreciate and acknowledge that in my conversations in the last year, that the Wilson and the East Merton Wellbeing Hub is probably 20 years in gestation. In that, though, we were able to identify funding from NHS Property Services and a top up from the CCG in the region of kind of up to £17 million. That would enable us to move forward with the Wilson redevelopment. But in doing that, the business case, when you're writing a business case, the better business cases guidance says that you have to revisit the options that were there before. So we went through due process. We had a number of workshops with stakeholders around comparing the Wilson alongside Birches Close and also Sibthorpe Road. And the Wilson came out as the preferred NHS option. And that was based on a number of things, but key to that really was the timeliness, the route to actually achieving it, because we have the funding, it is an NHS property, we can get started relatively quickly. And it would enable us to really move forward with the Wilson debate that's 20 years, as I said, in gestation. So the programme board that was established to oversee this agreed that Wilson would be the preferred site. We move on to a process of writing a business case to that. That's where we're at the moment. We're in conversations with our mental health trust around what services would be delivered from that. It should tie into our local estates plan. And just to say that our estates plan, we want to bring back into kind of being a Merton run plan to make sure that we are really covering all things from primary care, but also really looking at the potential between ourselves and our local authority colleagues. Much of the services that we're talking about are preventative services, health services, well-being services, but also mental health. And that goes back to some of our JSN, Joint Strategic Needs Assessment, and our Core 20. So really looking at the services that would serve East Merton. The other thing that I just want to say is that we don't see the Wilson as a standalone development. What we need to be looking at is not just the Wilson, but also actually what are we going to do with the proposed site at the Rowans and also the Colliers Wood, where Merton Vision are going to move back in. So that we need to start looking at the different opportunities in different sites that can link some of this up as well, so that we're starting to build a network of great services. That's where we're at the moment, and we're just writing the business case. But really key to the business case was actually the deliverability of it. We could do this in a relatively short period of time, and I mean a couple of years. And secondly, we have the funding, and we have the funding in place to get going with it as quickly as possible. I'll leave it there and ask for questions.
Any questions? Brenda?
Sorry, thanks, Chair. Mark, did you just mention Rowan? Well, I think I need to lie down because it's over 10 years. I'm growing grey with worry and thoughts. People are moving out from that site because what they were promised, we're not getting it. We get promises, hollow promises. And there's a huge sign that says coming soon, 10 years ago. And I thought I need to get my dictionary out. Soon doesn't mean to us what it means to Cress and all of that. We've had lots of people come on site, and we keep getting a date. Oh, it will be 2 years' time, then it will be 3 years. I'm sure I'll be dead and buried next door before we ever get that place. And I'm really annoyed that I'm at the forefront because I'm one of the councillors who've been there the longest when it all started. And so people keep this, I think I have a hand in not getting it done. And we've looked, and I've taken doctors who tell me that they didn't even know the site, local doctors from the partnership. So we've been there. We've now joined with the Scouts. We couldn't find them, and yet we can't move forward. Recently, all the hoardings almost fell down, and I was worried about travelers moving on site. I had to go over there and write notes saying, please don't walk on this, it's dangerous, whatever. And got the council and others to help. But we're not getting anywhere with it, and I'm worn out. So I'm probably going to have to charge somebody for my mental health.
So again, I completely acknowledge that many of these estates issues are long-standing, and that there's been promises about developments, etc., going on. What I can tell you is that we have recently been in contact with the developer. We've also been in contact with the local practices. We are having three-way conversations to ensure that we are all signing up to the same thing. We hope to come back to you very soon with the plan around the Rowans. I mentioned it because I do think it's relevant in terms of developing East services in East Merton for people in East Merton, and there is definitely potential there, and there's a site that has potential moving forward. I can't tell you about the plans at the moment because we've got to. I don't want to come out with false promises. I actually want to come out with something that's signed up. We know who's got the lease. We know what the development plan is, and we know what the design is. But that is part of the local estates plan that I mentioned, and it really is bringing that back to kind of the borough committee that I mentioned before, but also the borough committee, the partnership, and also the health and wellbeing board is actually really bringing it back to Merton owned and Merton discussed. So.
Rowan surgery itself is virtually non-existent. If you walk around there, you know that it's derelict. It isn't really. And I've had lots of meetings with the doctors involved, and no one seems to be taking any notice. People are dumping things on the site. Next door, somebody, number 3, Windermere, they've opened the fence, brought their vehicle in, washing it on site. And people are complaining on a daily basis, and they're leaving the surgery. So by the time you even think of doing anything, there won't be any patients using that site.
So just to say that, yeah, I know that the current property, one of the things that's been raised to us, one of the things that would the rationale for getting on with this because actually the premises are just not fit for purpose. The practices are really struggling hard to even recruit people to work there. That's a critical factor for a GP practice to have to manage on a daily basis. So that is one of the key factors in us trying to therefore do something about it. And hence my conversations with both the developers and the local GP practices. So as I said, I'm more than happy to come and have a conversation with you outside and also come with you to the site. Fantastic. And
I think you've made your point, Brenda. And can I come back onto the other issue? Can you explain why it is that you've got money, but only if it is in a particular spot? Because again, if you look at it, the Atticus Finch approach to life, walk around inside somebody else's skin. If you live in East Merton and you hear that in your part of the community, life expectancy is much lower, and then you've got the local hospital where you were born and maybe your children were born is being moved to Belmont, and they occasionally drive past Wimbledon Chase Station and see what's been made available to people in a more affluent part of the borough. Can you not understand why people feel a sense of grievance that the people that have get more and the people that have not get nothing? And, so why is it that it has to be where I mean, this assessment that you've done is not something that I've been involved with, but why can't money be available in the place that best suits the community that facility would serve, as opposed to in the place that best suits NHS property services?
So key to that is that within the NHS property services disposal, the investment needs to be back into NHS property. That said, we in light of this conversation that we knew we were going to have, we are reaching out to our local authority colleagues to see if there are any ways around that. But the reality is that also I think we have to be pragmatic in terms of the length of time some of the other developments are planned for, or there are no plans for yet. So we will go around that loop again in terms of looking at and talking to our local authority estates team. We will look to see if there's any flexibility in terms of that disposal policy. We have been informed it's not, but we'll go through the loop again. And I suppose it is about keeping some estate within the NHS, so investing NHS money in an NHS estate. So we will go around that loop again, but I do think there are two factors. I think there is timeliness. So if we want to get on with the Wilson, we have a kind of clear route to delivery with the Wilson that perhaps we don't have with the other sites. And we've also got a kind of design and a set of services that we're in conversation about bringing them into the Wilson as well. So, but I'll happily go around the loop again.
Would be very grateful. Thank you. Any other questions on that or comments? Thank you. So the next item is the pharmaceutical needs assessment, and that's Dagmar.
Yeah, thank you very much. Quick reminder, I'm aware of time. The P&A or pharmaceutical needs assessment is a statutory duty of the Health and Wellbeing Board. Slight oddity, to be honest, but we got it 2015. It's very prescriptive. It tells us we need to have one, what it looks like. It needs to be refreshed every 3 years. It is actually a tool that NHS England and now NHS EI are using to regulate market entry. So they use it to determine when pharmacies are applying to come to Merton, whether to agree or not to agree. So that's just the context, whether we think that's sensible or not. leave that to one side. We have to do it. We try to make the best out of it. Pharmacies are really an important part of a primary care offer. We're describing in the paper what the process is. We have commissioned an external provider to help us. It's quite an onerous task, and there are providers out there that have a lot of expertise. And what we are asking you as board to do is consultation is quite an important part, prescribed part of the pharmaceutical needs assessment. And the consultation is going to be prepared, and we would just like you to first of all comment and be active in that consultation, and if at all possible, share again the consultation with your networks so that it is as meaningful and as widespread as possible. And then the second ask is that you will then delegate the decision for the final amendments to the final draft to me, so that we can hit the deadline of the final P&A being published on our website by 1st of October. That's it. Open to your question.
Can we agree these recommendations? I see lots of nods. So let's agree the recommendations and let you get on with it, Dagmar.
Thank you very much.
Item 9 is the biggest issue, and that's Mohan.
Thank you, Chair. I think I've got some slides. It's just two, and it's one of the initiatives which is currently taking place as part of the Merton Health and Care Together, and it's looking at weight management. So it's looking to see how we can support healthy weight, and we know that in the UK, that 60% of adults are overweight or obese, and this is the next pandemic. So we know what we talked about smoking before, but smoking was the real issue 20, 30 years ago. It still is an issue, but we've managed to curtail that down. Now what the biggest issue we've got at the moment is around obesity, and that will impact on us in later years. So how can we identify what some of the factors are around that? And there will be some of the themes we've talked about before, some of the health inequalities, some of the outreach, some of the social factors which we need to identify. So the Merton Health and Wellbeing Board has a long sort of focus on child healthy weight and diabetes, and there was certainly some fantastic work just before the pandemic for the Diabetes Truth Programme, which we can align this piece of work. I'm involved in a South West London Yale programme which looks at trying to identify people's or individuals' feeling or behaviour around healthy weight. And so we want to understand the barriers and challenges faced by our community in making lifestyle challenges. And so we'd like to bring this to the Health and Wellbeing Board in September. So we've got 3 phases. So the first phase is to survey as many members across Merton, and we've got a QR code, and the survey's gone through a lot of members of the community and health and wellbeing team, and so it's quite strict. And once we get the survey back, we'll then go out and do some community engagement and find out some further insights as to what some of the issues are. We have got some branding, and then the phase 3 will be feeding into the Diabetes Truth Programme to try and work out how we identify and take this forward in future strategy. And if we move on to our next slide, we have got some branding, which is the biggest issue, which is this orange T-shirt. So I did dress up for this evening, and the biggest issue being weight management, something we need to address now. So the members of the team are the guys at the bottom, myself, Annie Murphy, who's the digital lead for South West London, and also Ina Liddington, who's a public health consultant in Kingston. And so we're sharing this survey. We've got 500 people signed up to it and have given their opinion. There's a £100 incentive, so I just urge you all to share this with your groups. I'm happy to share the links afterwards. But hopefully we'll get some good feedback and some good information in terms of where to do our next focus group. So I just want to bring that here, and I'm happy to, we're running out of time, but I want to just bring that here, and we will have a further discussion in September. Thank you.
Well, thank you. And are there any comments or questions on this? Well, how can we help promote this, Dagmar?
So I think Mohan's request was you all have networks, and I think in the slide pack there are the links and the leaflets. So if when you go out and meet people, you just spread the message. So it's amplification through your networks. Mohan, is that correct?
That's absolutely correct. So we're also doing a social media campaign as well. So we're hopefully going to get it everywhere, get as much information as we can, and then we can sift through all the feedback we get to then bring that back here to then come up with a strategy about going forward. So yeah, I urge you to utilise your networks. Thank you.
What about, I mean, is the council's communications team involved in this already?
I have to admit, I don't know yet, Clarissa, but it's something that if the councillors are happy with that, we can absolutely arrange.
I think that's the least we can do to support Mohan's work, which I would like to commend. And, that's a very simple step that we can take to get out to networks. And if any other members can think of other ways of doing it, then please do let us know and we'll do what we can. Could you talk to them in the morning, please, Dagmar? Thank you. And that's our wish as Health and Wellbeing Board. Thank you.
Thank you.
Mark.
Thank you.
I was just going to add just around Merton. Mohan mentioned it about Merton Health and Care Together. The partnership is actually, we take it there as well and make sure that we're advertising it across all the sectors. And just to assure you that our comms team as well is going to be involved with Mohan just to link up across the various comms teams so that we're getting out there as much as we possibly can.
And presumably your colleagues in surgeries around the borough have been drawn into this and are supporting it.
Yeah, so we're in the implementing stage of getting this word out as much as we can. We are focusing on the deprived population, so certainly the East Merton Primary Care Network is heavily involved, and we have shared it with some of the other practices across east of Merton as well. So the more the better, I feel, in terms of getting people's information and feedback.
What about the voluntary sector? Are there any of you still with us and willing to use your networks to get the word out there?
If I can come in, Chair.
Sarah?
Oh.
Yes, absolutely. We're committed to sharing it across all our social networks and with our partners, of course. Anything we can do to get on board.
Sorry, Simon, I interrupted you.
No, not at all, Chair. No, just to say we always support anything that Mohan's doing. So yeah, it goes without saying that our newsletters, our website, our social media channels will support this, if indeed we're not already on the subject. So yes, consider that as a big yes from us. Thanks.
Thank you very much. Okay, so I think that concludes our agenda. But before we close, I wanted to say something to Vasa, because I understand that you have that you are stepping down, and as the new chair, I've had to send out I've had to gather intelligence reports on what you've been up to and what's been going on. But I mean, it's quite clear to me, and I understand from them that the contribution that you have made has been enormous. And they referred specifically to your first impassioned appearance at the Health and Wellbeing Board, calling on partners to take action to tackle diabetes together. And you've been a vital part of the work that we do. And as Vice Chair, you've always encouraged us to think about the patient or local resident and see things and how to be aware of the day-to-day struggles that they face. And I think that's been quite apparent this evening. And throughout the pandemic, you led the way in encouraging communities attending numerous community championing sessions and vacation webinars, answering questions honestly. And there's a thing, answering a question honestly, and taking time to give reassurance to those who needed it. And your compassion and your ability to see things from their point of view. The Atticus Finch approach to life is one of the strengths that we as a board will miss. And I would like to thank you for the huge contribution that you've made to the Health and Wellbeing Board and to Merton as a whole. The board will miss you, Vasa, and we wish you the very best of luck for the future. But don't think you're kind of just getting away without hearing from us again, because we know where you are, and we will continue to rely on your input and contribution. And I'm really sad that as I join the committee, you're off. I hope the two are unrelated, but I suspect we might have been very good allies had we had longer to work together. But it's really important to say thank you. Saying thank you costs nothing, but is so very important when somebody makes the contribution that you have. So on behalf of this committee, I'd like to say thank you. Or this board, I should say.
Thank you, Chair, for your kind words. And I really must thank everybody who has been. Thank you, Dagmar.
That's our tradition.
Thank you.
You happy to.
Thank you, Dagmar. It was truly a partnership. It was not health, it was not the borough, it was both together. And that's what we did in the last 2 years. And I sincerely hope we can continue in that spirit of fellowship, togetherness, because that's the only way we can deliver for our patients. Anything else will not cut it.
Earlier on of the importance of applying water to things that are growing and nurturing them. So I hope that that you will take the advice offered earlier by one of your fellow doctors and make sure that thrives and grows and develops. But thank you very much. And I declare the meeting closed, and I apologize for keeping you here so late.